Hello, I'm Neil Spooner, the chair of the Patient-Centric Sampling Interest Group. I'd like to welcome you to our latest webinar. I'm really excited this month we're going to be featuring Giovanna Forte of Forte Medical UK. And the title of her talk is Unreliable Point of Care Urine Collection, Putting Women on the Front Line of Antimicrobial Resistance. So welcome, Giovanna. Before we get started with you, I'd just like to thank our partners and sponsors who provide the funding for us to be able to have these monthly webinars and a collection of them on YouTube, and perform the other activities we do to help move forward patient-centric sampling. So thank you to all of our sponsors. Just a reminder, this is being recorded and will be available in about a week on our YouTube channel, so you can review it there. Please use the chat function to submit your questions for Giovanna. And with that, I'll go off screen, Giovanna, and hand it over to you.
Thank you very much, Neil. Hello, everybody. This is rather a privilege to be speaking to this audience. I'm going to run you through why we believe women are on the AMR frontline, which is all quite interesting. It's going to involve a bit of participation from you. So what I'll start with is that there is no such thing as a simple urine test. We see these headlines in the press and we listen to it, everywhere. A simple urine test will do this. The thing about urine is that different parts of the stream will carry different sets of information. And that's why guidelines for UTI and prenatal screening, I'm screaming, it does hurt, specify midstream urine. And first stream is required for certain early stage cancer tests listed here. And then for sports and evidential forensic medicine, you need twin stream. So the A sample is tested, the B reference sample is frozen. So you can see that the needs of urine collection are a little bit more complex than a simple urine test. And we'll go into this a little bit more. We're going to do a survey. We're going to start with the survey. So I think that's going to come from Philip. Where are we? Here we are. Let's see. This is interesting. Look, it's all moving around. This is very exciting. Good, good, good. Keep going, everybody. Yeah, well, you're all pretty well informed, I think. So, right, okay. Yes, 400 million is how many women suffer from UTI globally. Average specimen contamination rate is between 15 and 30, so you're pretty spot on there. Interestingly, I did ask AI what the global contamination rate was, and it came back to me with 57%. So I think we're erring on higher rather than lower. Poll 3, yep, 30% of women get a recurrence. And 4, this is an interesting one. I've combined the resistance to one common antibiotic and 2 common antibiotics, and that does combine to 86%. And I'll go into that a little bit later. So actually, you're all pretty well informed, which is very good, very good. Now, should we end that? Oh, show results. There we go. Yeah. Right, going back to the presentation, we've got half of all women will experience UTI in their lifetime. That's 400 million globally. In the UK, 1 to 3% of women go to the GP. So about 10% of all GP appointments are for women with UTI. And 30% of these will be retests and revisits, and that costs an awful lot of money. They're also getting antibiotics that they may not need, which is why they're returning within 3 months. So UTI is not a minor condition. It's actually a driver of AMR because of the lack of diligence in handing out and prescribing antibiotics. So we've got a global guideline for midstream urine for UTI and prenatal screening, and yet it does not appear in the body of the flowchart, the primary care point of care testing flowchart for UTI. It appears about 6 pages later. So if it is guideline, why is it not in the actual flowchart telling, advising GPs and nurses what to do? So that's the first problem we have. Dipstick technology is commonly associated with false positives because it will respond to contamination in the sample, and contamination occurs when debris, bacteria and cells will wash off the labia and into the urine sample and contaminate that urine sample. So in effect, a contaminated sample is a bit like asking a lab technician to look through a dirty window and tell you what's on the other side. And that frankly is not good enough. You wouldn't get that kind of a standard with blood. The culture is not normally done at first visit. If it's a positive dip, whether or not it's positive from contamination, a woman will get a 3-day antibiotic. So we're really, this system is built for convenience, the doctor to, get rid of the woman, clear the waiting list, and not taking account of the fact that chances are she might come back. So there's unwarranted cost here. There's unwarranted cost in the prescribing and the repeat appointment and the doctor's time. So we've got, 60% of women will receive a common antibiotic prior to culture. Now, the AMR guidelines recommend very strongly that problem bacteria is identified before an antibiotic is given because it should be a targeted antibiotic. Now, this as we've seen from as I've indicated from the pathway, this is largely ignored. And we've got 92% of bacteria already resistant to at least one antibiotic and 80% to 2, which is where the 86 figure comes from in the questionnaire. So the thing about the broad spectrum antibiotics is they will mask the symptoms largely, but they won't actually tackle the problem bacteria. You need a stronger targeted antibiotic for that. So I know a lot about this, partially because I've built this business from a concept invented by my GP brother, who invented this, by the way, because he was fed up with women asking him to pee into this. Because it was unhygienic, undignified and inaccurate. So at the age of 18, I went to my GP with what I suspected was cystitis. And he completely ignored me because I hadn't had it before and gave me what the pharmacist described as a placebo. And I ended up all night peeing clots of blood with a high fever. And I cannot begin to tell you how painful that was. And that level of UTI will often go to the kidneys if it's not treated. Age 34, I had a failed 3-day antibiotic and my female GP refused to culture a second sample that I took, having taken it with PZ, and looking me up and down rather suspiciously told me to go to an STI clinic. I asked her on what basis and she just shrugged and told me to go. I did go to the STI clinic at Bart's and they said, you have a raging UTI and it contains bugs that are known to be resistant to I think it was trimethoprim she gave me. And they put their head in their hands, as did the hospital doctor who I saw with early stage sepsis after I had had 2 failed nitrofurantoin prescriptions, both 3 days. And when the GP gave me the second one, I did point out, you're not supposed to give the same antibiotic twice if the first time it hasn't worked. And she got terribly cross and told me she knew what she was doing, gave me the prescription and told me to go. So you can see that the way women are treated with their UTIs is a nonsense, and it's not helpful. It doesn't treat us. And basically the way we're treated now is a huge driver of sepsis and AMR. In fact, sepsis, I think it's between 20 and 25% of sepsis cases come from poorly or badly or untreated urinary tract infection. So there's a thing. Now, in pregnancy, what you don't want is for a pregnant woman to get antibiotics she doesn't need, because I've read papers describing how this will impact the microbiome, not just in the mother, but in the child. And that impact will have a longer term effect, potentially creating a propensity to obesity and diabetes for the child later in life, and also heighten the risk of AMR. So immediate antibiotic prescribing is still recommended for pregnant women, which I find extraordinary given that this can adversely impact the mother and child. And given the state of what we've been reading about our maternity services, this absolutely has to change. So now here's an interesting thing, and I've asked many people why this is the case. For women, the Public Health England care treatment pathway recommends immediate prescribing for women, and yet always send a midstream urine culture before antibiotics are given to men. So why is this? Is this because fewer men get UTI and so they're not bothered about spending the money on culture, but they can't be bothered to do it with women because there are a lot of us? If they cultured it, there wouldn't be so many. So the Pharmacy First initiative came in to relieve GPs of the burden of women presenting with UTI. Now, what this means is that I can walk into my local pharmacy and give them verbally two symptoms of UTI, on which basis they will give me a broad spectrum antibiotic. So that pharmacy will receive £15 for that consultation. You can see there over 660,000 visits in the first year. And when that UTI returns within 3 to 6 months to a GP appointment, you're spending more money on diagnosing and treating that woman. So if you had an immediate culture for the UTI for the midstream specimen, then you're going to reduce the number of people going either to the pharmacy or to the GP, but certainly saving the NHS an awful lot of money on those resources and those repeated touch points going into each facet of the NHS. I don't know if you can see this very clearly. We've mapped out what the worst case scenario with failed Pharmacy First, failed GP prescribing against what we would like to see, which is a cultured midstream urine at first visit with a painkiller, which I know is effective. If I've had a UTI since, I've insisted on culture and I've taken a painkiller in the interim. A cocodamol does the trick beautifully. You don't feel very much. And then you wait for your targeted antibiotic and you are cured within 7 to 9 days. And you can see the financial benefit that has for the NHS. Fewer touch points, fewer resources, and a big saving with women being treated right first time instead of the hit and miss system that we've got going on now. So what we would like to see is genuine midstream urine collection mandated, and education. We had an interesting scenario with some midwives recently in a test who said, we don't understand why we need midstream. If it's not right, we'll just do it again. And we can't be bothered to tell people how to use our urine collection device, which I'll come on to later. So there's an education piece to come on here. And we must mandate culture prior to prescribing. There are very few other conditions or infections where you wouldn't be properly investigated before an antibiotic was given. So why UTI, the most common infection that women suffer from, is treated in such a cavalier fashion, I don't know. And finally, the UTI guidelines need to be synchronized with those for AMR. In other words, identify the problem bacteria before you prescribe so that you're not just wasting broad spectrum antibiotics and creating an issue further down the line, because these prescribing guidelines are detrimental to women. And there are an awful lot of us. We are 51% of the population. So I think the key thing here, having spoken to my own GP, people insist on an antibiotic. People get aggressive if I won't give them antibiotic. Every GP surgery needs to be powered with a leaflet or something to explain to patients that if this carries on in 10 years' time, they're not going to get treated for anything. I mean, we're going to be facing a diagnostic debacle, a complete disaster. And we need to act on this now. We need to integrate rational antibiotic use to medical undergraduate training. Now, it's interesting to know, I know several trainee GPs and nurses who have told me that midstream and the value of accurate urine collection is not touched upon in medical training or nursing training. Why? Why? I mean, I'm sure they're told about the value of accurate blood collection, but why not urine? Because there's an awful lot more of it that goes on. So the toolkit for patients and a toolkit for medical training is really valuable. It's absolutely essential. And precision diagnostic vaccines, that's all good, but if you haven't got the basics right, the rest won't follow. As Bart's microbiology manager said to me, rubbish in, rubbish out. If you don't get the basics right, nothing right will follow. So we need precision, we need prevention, all of which will lead to responsible antibiotic use. But this needs to be taken on board by every facet of the medical profession, from student and education right the way through to consultant. Here we are. Here's the portfolio of urine collection devices that's on the market right now. And the inventor of one, I won't say which, told a colleague of mine that no, it doesn't automatically collect midstream. The patient still has to put the vessel into the urine stream. But as far as we're concerned, for UTI, it is adequate. Now, I don't know who would welcome the word adequate into any description of their diagnostic treatment. I certainly wouldn't. The other point with most of these is that they will wet your hands. They'll probably wet your legs, clothes, and the loo. Now, how much has the NHS spent on Clean Your Hands campaigns? I would concur that it was millions. And yet, they are still asking women to soil their hands to provide a urine specimen from which 30% are unlikely to be diagnosed. That makes no sense at all. As far as infection control and patient safety go, this is not working. So, as I mentioned, my brother was an NHS GP for 30 years. He also co-wrote a reference book called Symptom Sorter, which some of you might know. It's a best-selling primary care reference book. He got fed up with women complaining about having to pee into this. Now, it's quite difficult for men as well, even with your inbuilt directional apparatus. But for women, it's virtually impossible. And the contamination rates are quite high and the hygiene is disgusting. So he invented PZ Midstream. We have evidence, primary care evidence, that there is zero contamination. This was in the Public Health Wales GP surgery. Up to 70% reduced false positive specimens, and those are the ones that are going to stimulate and trigger unnecessary antibiotic prescribing. So that's a high figure. It's between 50 and 70, and a 66% saving on lab spend for that GP surgery. Now, when you look at the financial difficulties that our primary care system is facing, that 60% saving on lab spend means a lot when you're looking at £15 per culture in the lab. And that leads to reduced antibiotic prescribing and long-term cost savings. Now, some few years ago, before managed service contracts, the lab said to me, we would not use or recommend use of your device because we are paid per sample, per specimen. And if you reduce those, you will reduce our profits. Now, with a managed service contract, if they have a fixed sum of money and we can reduce the amount of work they do for that, we are hopeful that things will change. But the decision for urine collection does not come from the lab. We would like them to support this to relieve their burden. The other thing is that with the Public Health England lab in Birmingham told me, well, we had a meeting with them and they had 3 lab technicians on long-term sick leave with repetitive strain injury because they were pouring urine from this into the primary tube that goes into the lab analyzer, which is what PZ Midstream will deliver the sample into. So precision and prevention, they impact the whole pathway on every level for the patient, the nurse, the GP, the midwife, and the lab. Faster than, cheaper than cure. So we have an accurate MSU, no decanting. I've seen, I remember when I was pregnant, it was a long time ago, you had to put your sample in a window and you don't know how long it sat there. In fact, end of last year, I had some tests and I was given a cup from the water cooler to pee into. Can you imagine? Can you imagine the collection of blood being treated so casually? Urine and blood have diagnostic parity, so we need to treat it with the same diligence that we do for blood, for all the reasons I've mentioned, for dignity and hygiene for women, which is coming into focus now, the patient experience, but most of all for right first time analysis, diagnosis, treatment, and accurate prescribing, not hit and miss. This might work, and if it doesn't, we'll do it again, because that's expensive, it's inconvenient for the point of care system, for the GP, and for the patient, who may have to take time off work. If they're pregnant, they have to lie to their employer because they don't know they're pregnant yet. The implications of this really are massive, and it has to come into view for transformation now. So women are on the AMA frontline, I believe, and the time to act is now, with mandating preventative practice, precision collection, to align the diagnostic and prescribing pathways, which has a massive, always has had a mismatch, and no one can tell me why. And we need to target responsible antibiotic use, educate patients, and save lives. So there's been a lot of talk about all of this. I did ask the former AMR champion for the NHS about a protocol for women's UTI so that the correct specimen is collected. And I was told to go and talk to nurses. So when you have people at high level championing things, you actually want things to happen. So action is needed, not words. There we are. It's not a niche concern. Women are not a niche patient population. We're over 51% of the population. We are caregivers, we are mothers, we are wives, we create a big chunk of the economy. We need looking after, and we need better than this. This is a public health priority, and we need precision for the most common infection that we suffer from on a regular basis. Thank you.
Thank you, Giovanna. That was
all your sources here, by the way. So I haven't been bandying stats at you. You've got the sources.
No, there was a lot of stats there, a lot of very useful information, a lot of very important information. So for those of you in the audience, please, if you can submit your questions for Giovanna via the chat function. While that's coming in, I've just got a couple of questions of my own. Mm-hmm. What is the actual rate of contamination of samples? I may have missed it in amongst all of those stats that went by, Giovanna. But what is the actual rate of contamination currently of midstream?
Technically, the NHS will quote between 15 and 30%, which is quite high, whether it's low or high. A few years ago, we issued a freedom of information request to every trust in the country, the acute trust. This is not even primary care, this is acute, for their contamination rates. And the stats came back. The lowest was below 1% and the highest was over 70%. So basically, the quality of your urine specimen will depend on, it's basically a national lottery. It depends where you are. Are you instructed? We've been involved in clinical trials where they've instructed the patient in very much detail on how to collect a midstream urine sample, which is either start to pee, stop, position the vessel under you, then carry on, or pee and push the vessel into your urine stream. So they're both pretty hit and miss. So, but that was described, that was instructed to patients in detail, and they just gave them a PZ pack and told them to get on with it. But we need a lot more diligence around this. And with a PZ, you do need first-time instruction, much like you do with a tampon or a condom or a COVID test. Once that instruction is given, the whole process is automated, clean and hygienic. So that below 1% to over 70% should actually be a figure at around 2.5% nationally.
Yeah. No, it's just a phenomenal failure rate at the moment. It's just a lottery, really, as you were saying yourself. It's just madness. So we have got some questions coming in. So we've got a question from Mary. Thank you, Mary. Is microbial culture the best way to identify the infectious agents, or is there a move towards PCR to monitor antibiotic resistant genes?
A little bit of both. There's quite a lot of work going on with DNA testing in urine, and we're given to understand by the people doing that midstream will help that as well. And there are also some new there's new technology coming in. We're working with a company called TACMed, who are developing an assay that will identify problem bacteria in urine within 30 to 40 minutes. So there are new tests coming in all the time, being developed. There's a lot of work going on in this space, but the accurate urine specimen is fundamental, front and center to all of those.
Thank you, Giovanna, and thank you, Mary, for your question. We have a question from Martina. Thank you, Giovanna, for the suggestive presentation. What is your thought about the potential implementation of this innovative toolkit for anti-doping analysis?
Oh, nice one. Well, we have 2 more devices. One of the devices that we will start to develop this year is PZ TwinStream, and that's for sports dope testing and evidential forensic medicine. So it will capture 2 specimens from the same stream. Now, for drug testing, it doesn't have to be midstream or first stream, because the drug will be present in whatever bit of urine you look at. So we've partially designed a device that will take both twin stream. So A is tested and B is frozen. So if somebody ends up in court because their career is about to be demolished, a sports career is about to be demolished because of a false positive test, they take out the B sample and test that. So I know that midstream is helpful, and because any urine, any part of the specimen is helpful for that. Our PZ midstream will assist, and it's much more dignified for the person concerned. The thing about the drug testing is that an official has to see the urine leaving the body and going into the vessel. So if we have a completely transparent PZ, that will work incredibly well. We're on it.
Yeah. And you can imagine with current approaches, contamination from things that the sports person has handled would be a problem within the urine sample that's collected, whereas with your PZ technology, that shouldn't happen.
There's no touch at all. So yeah, I mean, if someone's trying to give a midstream and they're holding the cup and the urine touches their hands, which are unclean, that goes into the sample, you've got a risk of contamination, as you do if the thing's just left lying around, which it quite often is. So yeah, diligence is key.
Yeah. So with these problems with sample collection and the way we're treating UTIs, is that a very British problem, or do you have data for other parts of the world, Giovanna?
We've I've looked at data from other parts of the world, and they're pretty similar. The US have a slightly higher contamination rate, as my research has told me, and speaking to various labs. And I'm getting quite a few emails now from labs in the US asking about this. We were selling PZ in the US before COVID. In fact, we were scaling to about 10,000 units a month in the US and UK. And then when COVID suspended point of care testing, we went from 10,000 units a month to 0, which was pretty nasty. So we're relaunching now, but the US was a bigger customer than the UK because they have a problem. The US military were buying. We were on one of the big group purchasing organization websites and so forth. So there is an appetite for this all over the world. It is a global problem.
Thank you, Giovanna. A really interesting question from Elizabeth. Thank you, Elizabeth. Do you have any recommendations for collection from bedbound patients or those with dementia who aren't able to do a midstream catch?
That's another good one. You're a good audience today. Yes, PZ can be held for a patient with dementia or who's disabled. If they can sit on a commode or on a loo, you can hold PZ in place from the tube, which means the caregiver remains clean. And also it's much more dignified for the elderly patient. My mother had dementia and she was disabled, and I would hoist her onto the commode, and having given her some water to drink, and then I would just sit and hold it in place and have a chat with her. And then when the urine came, it came and filled the tube, and the PZ worked. I mean, I didn't get soiled. She was dignified because her genitalia weren't exposed to me. They were covered up. And that's a big thing for elderly women. Yeah, you don't want a carer you don't know staring at your genitals. Who would want that? It's, it's really unfair and undignified. So yes, this is very good for that. Bedbound, not so sure unless you can get this underneath, and there is that kind of depth there. So I'm less sure about that because I haven't tried it. but certainly, on a commode or a toilet, it will work beautifully.
Oh, I mean, it's amazing, amazing. Thank you for that question, Elizabeth. Question from Amy. Does the PZ help with pediatric urine collection from non-toilet trained children?
No, pediatrics, we need a child to be able to hold at least 100 ml of urine. I know that's difficult to tell, but basically, if they can walk and they can sit on a potty, then the chances are it will work. But younger than that, there is a woman called Angela Davidson who's got a company called Tinkleguard, and she's invented a nappy that will collect midstream urine from babies. So you can turn to her for that bit. That's not our bit, with a bit more, slightly more grown up version.
I love the names, Tinkleguard and Peasy.
Well, when we started out, my brother called this the female freedom funnel, and I did say to him, that's so not going to fly. So we came up with Peasy Midstream, and he wanted the funnel to be in the company name. So for a short time, we were called Funnily Enough Limited. But no one took us very seriously, so we became Forte Medical, which is a little bit more dignified.
Yes, yeah. Yes, no, absolutely. Any more questions from anyone in the audience at all, please? And I'm sure that if you think of questions after the event, please send them to myself, Neil at pcsig.org, and I'm more than happy to hand those over to Giovanna.
I'm more than happy to answer any questions you might have. My email address is on LinkedIn, and I will always copy Neil, so that if you reference this webinar, I will copy Neil so he knows who's asking what to whom and why.
Yes, you're very good at LinkedIn, Giovanna. Thank you. And always a good proponent for PCSIG. Thank you for your support.
You're welcome.
So I'm just going to, Mary says, thank you for a great talk. Thank you, Mary.
Yeah, my pleasure. Thank you for being here.
I'm just going to, for those of you that aren't aware of the Patient-Centric Sampling Interest Group, we are a not-for-profit organisation that brings together a variety of interested parties who wish to develop and promote the use of patient-centric sampling technologies for blood, plasma, urine, and other human matrices to better facilitate the advancement of human health care and well-being. And if you hold your phone up to the QR code on the left, you can find lots of information on our website. Hold your phone up to the QR code on the right. You'll find our LinkedIn group, which you have to ask to join, where you can ask questions, share information, learn things. Please contact us at contact@pcsig.org. Just with regards to other upcoming webinars, we've got on April the 15th, we've got Rachel Carling, who's biochemical sciences at Sonova, who's going to be talking to us about evidence versus adoption in PKU monitoring, understanding the implementation gap. And then we've got Jenny Van Eyck in May talking to us about analytical mass spectrometry workflow for VAMS, which is volumetric. I should remember this. I helped invent it. I can't remember what VAMS is. Anyways, James, I apologize for not remembering what VAMS stands for, and its application in cardiology and beyond. So please, and keep on looking for our webinars. There's a new one every month. If you've got suggestions for a webinar, please write to us. We now have a back catalogue of over 30 webinars, and the viewership on YouTube is phenomenal. So thank you for all of that. I'd like to again thank all of our sponsors and supporters who make this all happen, and without who we wouldn't be able to hear these wonderful case studies of patient-centric sampling really making a difference to patients. And with that, I'd like to say thank you again, Giovanna, and thank you to all of you in the audience, and see you next month.
Thank you, Neil.